One unfortunate thing I must say about this focus on harm reduction and this whole kind of paralysis around its future is that it has truly prevented us from moving forward on other fronts. Look, you know, Insight is doing what it's supposed to be doing. It's met its basic objectives. It's a small pilot facility. It is by no means a panacea. And I think, as illustrated by our work on overdose, its coverage is very limited. We don't have a comprehensive program of supervised injecting. The neighborhood could use probably at least another 2 or 3 facilities, but really there's so much more we could do. But also this focus led some commentators to argue that really the 4-pillar plan had failed, that really all we had was harm reduction and policing. However, our own cohort data showed that over time there had been a massive increase in the number of people entering addiction treatment, in particular methadone, and there had also been, as indicated by the blue bars, a fairly significant decline in the proportion of people who were reporting difficulty accessing addiction treatment. And these trends were really mirrored by massive increases in expenditures in addiction treatment. Some of you may also know that Vancouver was home to a very long anticipated and expensive heroin prescription trial done by researchers outside of our group. The results were published not long ago in the New England Journal of Medicine, and like other heroin prescription trials, showed positive outcomes in terms of reduction in illicit drug use and illegal activities and retention in treatment. Sadly, there has been no access to the study drug post-trial, leading a lot of people to complain about whether this trial was ethical in the first place. And at this time, there really is no concrete plan to ensure the continuation of the program. One thing that was interesting about it was there was an arm that included giving people Dilaudid, and people in the trial could not distinguish between Dilaudid and heroin, and now there's going to be some efforts to try and see if we can't initiate a new trial that would involve comparing Dilaudid versus methadone. So at this point, I think it's useful to ask yourself, is harm reduction working in Vancouver? Well, clearly, I think many of the studies I have shown you suggest that the various programs are having some positive benefits, but really at a very broad level, when we look at the number of new HIV infections among folks who inject in British Columbia, you can see here in Vancouver there's been a very steady and rather dramatic decline. And while the overall trend is to a decline in other parts of BC, it's clearly not as dramatic. We see a similar effect when we look at overdoses over a 9-year period. Here in Vancouver, you can see a spike in the 90s and then a very steady decline, whereas in the rest of the province, there's been something of a decline, but it's clearly not as dramatic as we see in the city itself. We're not without our challenges still. I think some good things have been done, but things are ever changing. And I think, as I was saying to Paul yesterday, one of the really unique things about Vancouver and the North American and even the global context is we just kind of seem to have it all. You know, there's a lot of heroin, there's a lot of cocaine, there's a lot of methamphetamine, a lot of crack cocaine smoking. And in fact, when we looked in our cohort of injectors, we saw a very large increase in the number of individuals reporting crack cocaine smoking over a time period. In a recent paper, we looked at whether crack cocaine was a risk factor for HIV infection. And over the life of the Vancouver Injection Drug User Study, we looked at 3 different time periods. And as you can see in the most recent time period, those individuals who were reported smoking crack cocaine on a frequent basis were about 4 times more likely to seroconvert. And we don't really know exactly what the mechanism. It could be high-risk sexual activity, but that's something we're exploring, but it remains a challenge. And while we've seen a lot of crystal methamphetamine use increase in Vancouver, what's also been very interesting and somewhat unique is that a number of people are now injecting it, and injecting methamphetamine use has been associated with syringe sharing in our setting. An exciting new frontier, I think, for harm reduction is actually the provision of antiretroviral therapy to HIV-positive injectors for preventative purposes. In this paper, we used our HIV-negative cohort and our HIV-positive cohort to characterize the median HIV viral load in the cohort, and then we superimposed the HIV incidence rate. And in a multivariate model that adjusted for other risk behaviors, we found that community viral load was the strongest predictor of HIV incidence in this setting. Unfortunately, there are still a number of challenges related to the provision of antiretroviral therapy to those who are HIV positive. For example, we found that 44% of HIV-infected IDU who initiate therapy discontinue therapy prematurely against medical advice, and the strongest risk factor for premature discontinuation is incarceration. We've seen a similar effect for adherence, with the number of incarceration episodes being associated with poor adherence in a dose-dependent fashion. When we approached BC Corrections about this, including the medical practitioners within the jails, they said, oh, look, you know, right before people get arrested, their life becomes very chaotic. They quit all medications. They stop taking antibiotics, antidepressants. It's not our fault. We're doing everything we can. It's their problem. So then again, using our multidisciplinary approach, Will Small, our lead ethnographer, used our cohort to identify HIV positive individuals who had initiated therapy prior to a recent incarceration episode. And he interviewed them about their experiences continuing therapy in jail. And what he found is that there was a whole host of problems that really predicted or really made it difficult to initiate or continue therapy in jails, including short-term interruptions in treatment during intake and transfers, delay in obtaining medications through institutional health care, very poor relationships between inmates and healthcare staff and concerns about privacy, as well as high levels of stigma, HIV stigma and discrimination. People were often beaten for being HIV positive, and disclosing your HIV status in a jail would also mean that you would not have access to the one rig that was circulating around the range. And there was also problems ensuring continuity of treatment upon release. Sadly, the government of Stephen Harper now is tabling a new tough on crime agenda, which involves initiating mandatory minimum sentences for drug offenses, nonviolent drug offenses, which I'm sure you all know have been well studied in the US and shown to be highly ineffective. And again, our group mobilized with other scientists to express concern about this, along with Aboriginal leaders in Canada. And that helped to generate a lot of attention about this problem, and it had it taken off the orders in Parliament right before the most recent election, but now that they have a majority government, I'm sure they'll move forward. But we've also been trying to really shed some light on the elephant in the room, which is the problem with drug policy, and really my colleague Evan Wood has really been taking the lead on trying to mobilize scientists internationally to speak out, feeling that we've all been a little too hush-hush about the very obvious failures of the war on drugs and the enforcement-laden approaches, which really mark the approach in most cities, and has created the Vienna Declaration with some other folks. And it's really just a call for drug policy to be based on science and not ideology. It's been endorsed by a number of prominent folks, including Nobel laureates and former presidents of many South American countries. If you haven't signed it, I urge you to go online and Google it and join in. I'm just going to conclude with a few summary points. I think it's fair to say that the body of science shows that harm reduction in Vancouver has been associated with some fairly significant declines in HIV transmission, fatal overdose, and other indices of drug-related harm. There's been, I think, a lot of factors that have been really key to success, but I think really having a multifaceted strategy. I don't think it's really possible to have a coherent four-pillar approach that's truly complementary. I think the evidence shows that policing too often interferes with the delivery of harm reduction programs. But certainly the removal of restrictive policies and programs was very helpful, and the involvement in drug users in program delivery and also in advocacy efforts were huge. I think multidisciplinary research has been really essential to demonstrating not only the effectiveness of harm reduction program and making a case for the continuation of innovative initiatives, but also identifying challenges. And I think in our context, although our group has often been criticized for being too advocacy-oriented, I think us playing a role in the policy-making process, be willing to speak out, meet with police and business groups who really hate what we're doing, has been very helpful. It's clear that drug enforcement, law enforcement, it has been a major barrier in our context, but I'm pleased to say that the Vancouver Police Department has really made a lot of gains. They have an official drug policy. They have a drug policy coordinator. We recently evaluated their efforts during the 2010 Winter Olympics and found no effect on use of harm reduction programs in the city. And again, they're actively referring people to the injection site and doing a number of other good things. Our harm reduction programs have really been under attack, and I hope it's clear to you today that we've really had to take some extraordinary actions to enact and preserve them, including taking the federal government to the highest court in the country. I think it's sad when the courts become the new frontier for the establishment of harm reduction, but really that's the reality. Unfortunately, while there's a huge amount of support for these approaches now in British Columbia more broadly, including among many enforcement personnel, we're still dealing with a huge international movement which would really prefer to see the preservation of the status quo. There clearly is need for some future work and directions. These include addressing the ongoing harms associated with crack cocaine and methamphetamine use, finding ways to scale up antiretroviral treatment and ensure that people really can remain on treatment even when they're in and out of jail, and also exploring alternatives to criminal justice approaches at the broadest level of policy. I just want to conclude by acknowledging the many people who use drugs, who participate in our studies and share their life stories with us, the folks who use Insight, our research staff, our partners at Vandu and at Insight and the Portland Hotel Society, the local Ministry of Health, and our funders, NIH, NIDA, and the Canadian Institutes of Health Research. If you want more information about our program, you can visit our website. We have there we provide a number of summaries of our research and plain language reports. We have a knowledge translation section as well. And if you need to get in touch with us, you can find out how there. Thank you very much.